It's HealthView on your talk station, News Talk 640 WFNZ.
And welcome back to HealthView. This is Dr. Angela Ruff, and our guest this morning is Dr. Kenneth Rich, neurosurgeon based out of Raleigh, North Carolina, Capital Neurosurgery. And again, thank you, Dr. Rich, for joining us this morning and sharing with us some great insight on your field and also some ways we can help prevent some spinal cord injuries. During the break, we were talking a little bit about some other. You actually participate with going to local schools and trying to help educate some of these kids of things that they can do to avoid these injuries that you see in your office.
Yes, it sort of goes back to the whole philosophy of think first, which we discussed a little earlier. It's so much easier to prevent injuries to the brain or the spinal cord than it is to treat them. Mm-hmm. Really, as much as I've been trained to treat them, I'd much rather spend my time trying to prevent them.
Right. We were talking a little bit about, I remember when I was growing up that one of the kids in our church ended up becoming paralyzed with diving into one of the local lakes, you know.
Right. I remember a young man, one of my first patients here in Raleigh 20-some years ago, who did exactly that. You look at a lake or a swimming pool, and you think, oh, I can dive in there, and you dive in, and you don't know the depth of the water. Mm-hmm. I mean, it might be 3 feet, it might be 8 feet, it might be 12 feet.
Right.
Very few people are aware of the fact that a good diver, now I'm talking about an Olympian,
right,
but a good diver off a 1-meter board, that's a standard diving board, mm-hmm, will go about 14 feet deep in the water.
Wow.
Now, I have a pool out back, and it's 8.5 feet deep, mm-hmm, and I do not have a diving board.
Right.
Because the second leading cause of paralysis from a neck injury, quadriplegia, is diving into water that's too shallow.
Wow.
And it's okay to dive into water, but what you have to do is get in first and check the depth. Right. The first leading cause, of course, is motor vehicle accidents. And actually, we've seen a significant decline in that because of airbags. Mm. They do their job. Seatbelts, too.
Seatbelts, too, yeah, they ticket you. Click it or ticket now.
Oh, well, it's not just ticket. I mean, click it, and with seatbelts, with modern airbags, mm-hmm, you can walk away from some just horrendous motor vehicle accidents,
right,
and survive them intact.
Right. Yeah, my nephew, he just got his first car right before Christmas, and so Christmas I got him this little car care package. We got these really cool ones at Costco, you know, everything you'd need for an accident. Mm-hmm. And so he got to use it shortly after I gave him that gift. But like you said, he had airbags, and he was wearing a seatbelt, so he walked away from it, but just totally totaled the car. Mm-hmm. And it could have been a very different outcome if he wasn't wearing a seatbelt or the car did not have airbags.
Right, and just like that coat we were talking about earlier that you lost when you were involved in an accident, you can get a new coat, you can get a new car.
Right.
But you can't get a new brain or a new spinal cord. You
That's
have to protect
right.
those.
Well, any stupid things I say, I blame it on the accident. It jungled my brain too much. But yeah, you know, it's nice that they have these really standard features in vehicles now that used to be optimal. I know the first car I learned to drive on, my dad's 65 Chevy pickup, it didn't come with even seatbelts, you know?
Right. I remember that too.
Yeah.
And again, you and I are dating ourselves.
Yeah, okay.
But, you know, a lot of people think that, oh, we've got airbags now, we don't need our seatbelts. No, that's not true.
Right.
The airbags are aimed at the passenger, the driver, and if you don't have a seatbelt on and you slide sideways, mm-hmm, before that airbag hits you,
right,
you may as well not have an airbag. So seatbelts haven't lost their importance. We've just added to the safety of seatbelts. You need to wear seatbelts.
Right, and of course, make sure, you know, if you have kids in the back, make sure they have theirs on as well.
Oh, absolutely. I mean, as silly a thing as just moving the car in the garage from the garage out to the the driveway around our house, everybody clicks their seatbelt on because it's just, well, you turn the key to start the car, you click your seatbelt on. It's just a habit, and that's a great habit to have.
Well, pretty soon they're going to make those vehicles where it won't turn on unless your seatbelt's clicked, you know?
Right, and you have to click them around you. Some people will try to click them behind them and this and that. I have patients with back problems that try to get me to write them a note to show the police that, oh, his back hurts, so he doesn't need a seatbelt. And I just tell him, I'd rather your back hurt than your brain be hurt.
Yeah, you think?
Yep.
Yeah, I've heard all that too. A friend of mine claimed she does that too because she doesn't like to wrinkle her outfits. I'm like, girl, you're gonna get a lot more wrinkled than that if you get hit.
Yeah, it's better to wrinkle your outfit than your face.
That's right. And they say that, a majority of the accidents happen within 1 mile of your house.
Mm-hmm.
So
that is true.
So it is smart to go ahead and get that on before you're really far away, because your odds are you're going to get that accident really close to home.
That is very true.
So tell me, for somebody like my patient who has, she's just in pain all the time and has just had this, chronic neck/back pain, what hope is there for her?
Well, again, to go back to some of the earlier things we discussed, most of them will be treated non-surgically. Mm-hmm. We'll use medicines and a wide variety of medicines, everything from the Motrin family, the non-steroidal anti-inflammatory drugs. We'll use very short courses of steroids. We'll use pain medicines. There are medicines that have a side effect of decreasing pain, sort of like aspirin has a side effect of making your blood a little thinner and preventing heart attacks. Mm-hmm. Those are like Lyrica and Neurontin. Mm-hmm. People use muscle relaxers. We'll use all sorts of medicines orally to try and control these. Usually that's the first step because it's so convenient. You don't have if you go to physical therapy or chiropractic or come to my office, you have an appointment. You have a schedule that disrupts your day. If we can get you on a medicine regimen that is safe and effective, then you are in control of it. You don't have to go to a scheduled this and that. It doesn't disrupt your work or your other daytime activities. So that's usually where we try to go first. Then we'll look at things like physical therapy or chiropractic, both of whom have excellent success with helping people control their pains, diminish their pains, and develop healthier habits for their back.
Right.
So we'll look at things like that. Now, that's a little less convenient than an oral medication because you have a schedule, but still, to get rid of your pain, it's more than worth it to do things like that.
Right.
And then we'll look at things like injections. People do trigger point injections, shots, where steroids or numbing medicines, local anesthetics are administered. And those usually, in my way of thinking, are going to be the third line of things that you throw at these back problems that won't get better by themselves. Not only here do you have a schedule, but of course somebody's sticking a needle in you. I don't like needles stuck in me, so I sort of look at those as, okay, that's third on the list. But, and then there's all sorts of other things that people do. They do, there's a new traction device out. They do acupuncture. Some of these don't have a real known medical basis to them. That doesn't make them wrong. If you go to have acupuncture next week and your pain goes away, well, I don't really care if it has to do with the acupuncture or not. Maybe it did, maybe it didn't. I don't really know. But I'm glad your pain went away and you did something perfectly safe. Right. And I'm not saying that's how acupuncture works either. I'm saying that we are a little bit ignorant about acupuncture. There's a lot to learn there. But people use things like that to avoid talking to people like me in operating rooms. Okay, well, if your friend went through those things and failed and still had miserable pain, then you start doing... then you start thinking about, well, is there a surgical option here? You look at MRI scans, maybe myelograms, CAT scans, things to try and give you a clue as to where could I target a surgery to go after this complaint that the patient's giving me. And if you come up with a good match from the studies, then you have a legitimate case to discuss surgery with the patient.
Right. And what I thought was interesting about the article was that there are other surgical options besides fusing the vertebra.
Well, fusing the vertebra is certainly one of the gold standard surgeries we're doing today. And for a select group of patients, it's something they have to explore. And for part of those patients, it's something that works well for them. There is a problem in that a disc, which is what you actually fuse, there's a vertebrae, which is a bone, and then a disc, and then another vertebrae. The disc is the contact point between the two. I like to compare it to grease in a hinge.
Mm-hmm.
The grease in a hinge keeps metal from rubbing on metal. The disc in your disc space keeps bone from rubbing on bone.
Right.
That is a moving joint. And every time I bend forward or backward or left or right or twist my spine, those joints have to participate in that movement.
Mm-hmm.
If you fuse one of them, it means you're stopping it from moving. You're taking the disc out of there and growing the bone above to the bone below. To the bone below,
mm-hmm.
so they can't move anymore. Well, that can work to reduce some people's pain, but there's also a lot of concern about the consequences of that. I have 5 discs in my lumbar vertebrae and 6 discs in my neck, in my cervical vertebrae.
Mm-hmm.
And if I take out one of those and then continue to move and twist and bend, the remaining functioning discs have to work harder.
Right.
And one of the things that causes the back problems or neck problems that we see in patients is wear and tear.
Mm-hmm.
Well, if something's working harder, it's accumulating more wear and tear over time,
mm-hmm.
and we think that might lead to a problem of the other discs wearing out prematurely, and some subset, some small group of our operated on, our fused population has to come back 5 or 10 or 15 years later and have another operation.
Mm-hmm.
Because of that, a lot of spine companies that make instruments and tools and devices for the spine,
mm-hmm.
are working very hard on making disc replacements. You know, we replace knee joints with a moving knee.
Mm-hmm.
We replace hip joints with a moving hip. But we're still fusing the spine. And we're going, well, wait a minute, where's our moving joint? We want a moving joint to replace these.
Right.
With.
So, but isn't that part of the prototype of what you guys are working with now?
We are working on a study, and this is for neck disc problems.
Mm-hmm.
It's not for all neck disc problems, but for a select group of neck disc problems, we're working on a study that the Food and Drug Administration has approved, and that means that the device is only available through the study. It is called NeoDisc. It's made by a company called Nuvasive out in San Diego.
Mm-hmm.
And it's one of the disc replacements that people are offering to the FDA to show that they can be as effective or more effective than the current disc fusions that we're doing.
How long have y'all been doing that study?
We have been involved in this study since October of 2006, so about a year and a half. We've got 9 patients now a year out from their disc study surgery.
Mm-hmm.
Half of these are disc replacements, and half of them are fusions, which are the current gold standard that we're doing. It's one of the funny quirks of the study that the patient goes to sleep not knowing what they've randomized to.
Oh.
So they get put to sleep, and they don't know if they're going to have a fusion or a disc replacement.
Huh.
Of course, everybody in the study is in the study because they want a disc replacement.
Right.
So about half the people randomized to a fusion and are a little disappointed, but it too is a good operation. We're just trying to make it a great operation if there is such a thing.
Right. Well, if you don't mind, we're just going to take a quick break, and when we get back, maybe we can get you to expand a little bit more about this new procedure. You're listening to Health View, and this is News Talk 640 WFNZ.